So it is my absolute pleasure to be introducing our speaker tonight, Dr. Brent Forester. Uh, Dr. Forester is the Dr. Francis S. Arkin Professor and Chair of Psychiatry at Tufts University School of Medicine, Psychiatrist in Chief and Chairman for the Department of Psychiatry at Tufts Medical Center, and Director of Behavioral Health for Tufts Medicine. He spent a quarter of a century of his professional career at McLean Hospital and Mass General Brigham, where he served as the chief of the Division of Geriatric Psychiatry at McLean and senior medical director for value-based care solutions in population health management at Mass General Brigham. Dr. Forester is an expert in geriatric psychiatry, specializing in the treatment of older adults with depression, bipolar disorder, and behavioral complications of Alzheimer's disease and related dementias. Dr. Forester's research focuses on novel treatment approaches to manage the disabling behavioral complications of dementia, such as agitation and aggression. His work also includes the implementation and evaluation of collaborative care models for comprehensive dementia within primary care medical settings. So with that, I would love to turn it over to Dr. Forester. Welcome, and thank you so much for being with us tonight.
Thank you, Chris, and thank you, Judy. It's really great to be here and to see all of you tonight. As Chris mentioned, I've spent my career essentially at McLean Hospital and Mass General Brigham. I've done a lot of work with Judy and her team, and Chris and Gabrielle, who's here with our integrated dementia care model. And I'm really excited to talk to you tonight about the dementia world today in 2023. My colleague at Tufts, who used to be with me at McLean, is here as well, Catherine Turner. Say hi, Catherine.
Hi, everyone.
Catherine is going to share her slides now, or share our slides now, so I can get started. And she'll be coming in at the very end to talk a little bit about some of the research that we're doing that some of you may be interested in participating in, and how we can have you reach out to us. So you can go to the next slide, Catherine. So what I'm going to talk about tonight is really three major areas. I want to talk about the prevalence of dementia in 2023, the impact it's having on society, both in terms of cost and the impact on patients and their families. I'm going to talk about how we go about diagnosing dementia in clinical settings, our current treatments, specifically also on the behavioral symptoms of dementia. And that'll be the first part. The second part is I do want to introduce you all to some of the ways we're thinking about how we need to re-engineer our healthcare system so that we can adequately assess and treat people with dementia and help support people on the journey. And then finally, I want to talk about what we can all do to help support our own brains as we get older in terms of healthy brain aging strategies. And I apologize ahead of time. I do put a little pitch in the middle of this talk about a book that I worked on last summer with my co-author, Tom Harrison, that talks about a complete family guide to dementia care, which I'll highlight a few of the key points from that book. Next slide. So every March, the Alzheimer's Association comes out with this amazing report, and I wait for it with bated breath, and it has a lot of facts and figures. And it always impresses me what a large problem this is for our society, not just in America, but around the world. And currently in 2023, we've got about 6.7 million Americans who have Alzheimer's disease or some other type of dementia. And because of the aging of the population, and especially the baby boomers aging rapidly, we're expected to see this number go up to about 14 million in the next 27 years, so by 2050. Right now, we've got tremendous costs being spent on the care of people with dementia, nearly $345 billion a year, with about as much being spent by caregivers that is essentially unpaid. Unpaid care for people with Alzheimer's disease involves over 11 million Americans and nearly the same amount of money that we're spending. The cost could rise to nearly $1 trillion by 2050, which essentially is unsustainable without a treatment or an adequate method for prevention. 1 in 3 people over the age of 65 in the United States either dies with or from Alzheimer's disease or another dementia. And it's the only disease in the top 10 causes of death in the United States where the numbers are going up in terms of deaths as opposed to down. What's not on this slide are two things. One, I just wanted to highlight that from an equities, a healthcare equity and a disparity perspective, older adults who are Hispanic or Black are more likely to have diagnosis of dementia and less likely to be diagnosed. So there's under treatment, under recognition in that population, and also under involvement in clinical research, so we can learn more about therapeutic safety and efficacy in those populations. The second thing that's not on the slide, which I wanted to highlight, was the impact of COVID on the older adult population with dementia. COVID directly led to an excess number of deaths within the dementia population beyond what one would expect based on where people who are older with dementia live, like in nursing homes or in assisted living facilities. And it also seems to have increased the risk for dementia in older adults who did not have dementia already. We don't know exactly why this is, but likely there's something related to the impact of this virus on our immune systems that has precipitated some of this escalating rates. Next slide. So one of the questions that I always get asked is like, I've got somebody with a memory problem, or I'm a primary care clinician and I've got a patient who's got memory loss, or I've got a loved one and I'm worried, what do I do? And I guess even though we've got a lot of interesting, cool technology to help us with diagnosis, and that's only going to advance over the next number of years, the most important thing that we need to do is to get a really good history. The story tells 1,000 words. It's often, I want to know as a clinician, when did the problem start? How quickly has it progressed? What may have been some precipitating factors? Did it happen gradually over time or all of a sudden? What domains of cognition are affected? Is it memory? Is it word retrieval? Is it getting the right words out? Is it someone's ability to organize and plan and think through their daily life? There are all sorts of aspects of history is key. And that history needs to be gathered not just from the individual with the problem, but also from their extended family and their close friends. So we have a good comprehensive understanding of what the story is. And then we need to look carefully at their medical situation, because there's so many medical problems and medications that can masquerade as a memory problem. People take Tylenol PM, for example, over the counter all the time to help them with sleep. Well, the PM part of that Tylenol is Benadryl, which is not only helpful for sleep, but it has the adverse effect of causing confusion. So we may find that there are treatable causes of memory problems by simplifying medications. And then we want to look at basic blood tests. We want to look at thyroid function and vitamin levels and other basic blood tests, because we know that unstable medical problems can lead to cognitive problems and are highly treatable. Second thing is we want to do some type of objective screen. If you have somebody who's experiencing memory loss and they have retained social graces, in other words, they seem fine in terms of their interaction, their personality, etc., and their language skills are intact, it's easy to miss a problem. It's easy for someone to cover up a problem. So you have to assess some type of, use some type of objective measure. Now, in a primary care setting, that could be a clock, a simple clock draw, or maybe a 3-item word list and a clock draw. We call that the mini-cog, or a more formal test like the Montreal Cognitive Assessment. But whatever we do, it needs to be something objective. And we need to screen for psychiatric problems or symptoms. We know that depression and anxiety and substance use disorders can all cause cognitive problems and may be the cause of the problem we're seeing in front of us and not Alzheimer's disease. And then some people, once all that's done, and by the way, all that can be done in primary care. It doesn't mean it always is done in primary care, but it can be done in primary care. We're often needed in the specialty world in a few situations. One is when there's a confusion about what's the diagnosis. And we might need to do other imaging studies like an MRI scan. Or we might need to do a more fancy testing like an a PET scan, where we look at blood flow or the utilization of glucose in the brain to see if there are metabolic changes in the brain. In rare cases, we may need to do a spinal tap or a lumbar puncture to look for certain cells that might be causing the cognitive problems. And we may need to refer somebody for more detailed cognitive tests called neuropsychological testing. So there's a lot that can be done in primary care, and there are some reasons to refer people then to specialty care. As I'll highlight in a few minutes, the problem is the first and the second bullet points here, although it can be done in primary care, often isn't because of lack of knowledge, lack of time, certainly not because of lack of interest on the part of the primary care clinician, but they often don't have the support in place to actually carry this out. Next slide. So one thing I always like to get straight when I give a talk about dementia is to make sure we're all set on the terms. So Alzheimer's disease represents one form of dementia. And as you see on the pie chart on the right, it represents about 2/3 of all dementias, with the diagnoses on the left remaining about 1/3 or so. So Alzheimer's disease refers to specific changes that occur in the brain due to the deposition of amyloid or tau proteins in the brain that lead to other changes and eventually death of brain cells. But Alzheimer's disease, which is, again, most commonly caused by, number one, risk is aging, and number two is genetics, but there are other factors we'll talk about. That represents about 2/3 of all dementias. But the older someone is at the time that they develop memory symptoms, the more likely it is that there's more than one brain pathology causing their dementia. It could be a vascular type dementia with small or big, large strokes in the brain. It could be the Lewy body type of dementia or Parkinson's disease, again, a movement disorder with other symptoms that causes cognitive and functional decline. And as you can see, a whole host of other things. So I think it's important that we hone in on the cause, because as you'll see in this talk, over the next few years, we're going to have more and more treatments that are going to be specific for the type of dementia as opposed to more general that we have now. Next slide. This is that module cognitive assessment. I'm not going to quiz any of you, don't worry. But as you can see, it tests about 8 domains of cognition. Visuospatial, executive functioning. You see that that cube you have to draw, and then I have people draw a clock on the top right and put the hands at 10 minutes after 11. I think for the current baby boomers, we all grew up with watches and clocks with hands and not just digital. But I think for the younger generation, they may have a hard time with this one day. That's not due to a cognitive problem. And then there's a naming test and a memory test and an attentional task and a language task. And anyway, all these are representing different domains of cognition, and we can assess where someone's strengths are and where their relative weaknesses are. And all it represents is a point in time. It's a cross-section in time. It's how someone's doing today. It doesn't say anything about yesterday or tomorrow. But if you've got a good baseline with a test like this, it's a great way to track change over time. Next slide. So now I want you to think about this continuum of Alzheimer's disease. And if you click the slide one more time, Catherine, I think there's, yeah, a couple more times. There we go. So there's this continuum of Alzheimer's disease. And Risa Sperling, one of my colleagues at Brigham and MGH, put this together a few years ago. But if you think about it, dementia represents the final end stage common pathway of something that starts a lot earlier in time. And for the point of this slide, let's just talk about the Alzheimer's type of dementia. The Alzheimer's type of dementia, which begins slowly, the characteristic symptoms are loss of memory, inability to recall new things. There are 3 stages. There's the preclinical stage where someone has the disease of the plaques and tangles in the brain and no symptoms. Then there's the MCI stage. That's the mild cognitive impairment stage. That's where someone has memory loss, but their day-to-day functioning, like driving, paying the bills, organization planning, all that is fine. We call that mild cognitive impairment. And then there's the dementia stage, which is the next stage, which is represented by not only a cognitive decline of memory loss, but now it's also affect day-to-day functioning in some meaningful way. What's really important to know from this slide, which comes from now the last couple decades of research, following people longitudinally over time with imaging and testing and all of that. Some of you may have participated, for example, in the Harvard Aging Brain Study here at MGH and elsewhere in Boston. If you follow people from preclinical MCI to dementia, what you realize is that there's been the development of the plaques and tangles in the brain about 20 years before someone develops the syndrome we call dementia. So if you're 75 and you got memory loss, these symptoms or the disease state in the brain probably began in your 50s. Now, if you think about it, one way I'm starting to think about this, and our colleagues are in this field, is like the cholesterol story and the risk for heart disease and stroke. If you're 40 when you've got high cholesterol, you take a statin today, not to prevent a stroke tomorrow, but to prevent a stroke in 20 years or in 30 years. And that's really, I think, what we're going towards in terms of the potential for prevention, is the earlier we intervene in this cascading pathway, the more likely it is we'll prevent these next subsequent stages and slow this decline. As you can see here, the top line is what we call quote unquote normal aging. Now, even in normal aging, there's some decline in cognition. It just doesn't fall off like we see in the disease state we call MCI and dementia. Next slide. So one of the common complications of dementia, whether it's the Alzheimer's type, the frontotemporal type, the Parkinson's type, or the vascular type, whatever the type, almost everybody with dementia will develop some behavioral symptom at some point over the course of their illness. And those behavioral symptoms are important to highlight because they're prevalent, they're disturbing to the person with the illness, and they're incredibly distressing to their family and to other caregivers. And it is the factor that is most associated with the trajectory of this illness in terms of people's independence and their quality of life and caregivers' own distress level and burnout. When I see somebody with behavioral symptoms of dementia, I'm seeing the end result of something that's probably been building for a while and is impacting what their course of illness is going to look at. And I think of this as being a very treatable problem. It's a whole host of problems. There's a lot of detective work involved in figuring out the causes of these symptoms, but it's incumbent upon us as clinicians to work together with our patients and their loved ones to figure out why are these symptoms happening and how best to intervene. And if you look at the symptoms I'm talking about, it's really the whole range of psychiatry. It's everything from depressed mood to anxiety to agitation to pacing and wandering to irritability to paranoia to hallucinations. And it can occur in different steps along the dementia pathway. These may be caused by three buckets of condition. The way I think about it is, one is there could be other medical problems that are driving these symptoms, like a urine infection or pain, or frankly, even a complication of COVID. We saw that quite a bit. Or it may be a medication side effect or related to use of like a drug or alcohol. So that's one bucket, is the medical bucket and the medication bucket. The second is it could be a direct result of something going on in their environment. It could be a burned out caregiver loved one who's like had it with the questions over and over again, who's basically feeling irritated themselves and makes their loved one feel upset. Or it could be in a long-term care facility around the change of shift. But there may very well be environmental precipitants, and then there may be psychiatric issues too. Maybe this person had a history of depression, or maybe they had a history of bipolar disorder, and now they're older and they've got cognitive problems. And now maybe what we're seeing is recurrent depression in the setting of dementia. That's a little bit different than depression that happens in someone with dementia who never happened to have it earlier in their life. And finally, I have to admit, there's an error on this slide because the last bullet point is no longer factually correct. There were no FDA medications for any of these symptoms until 2 months ago. And in early July of 2023, the FDA approved the first drug ever to treat the behavioral and psychological symptoms of dementia, specifically psychosis, in people with Alzheimer's disease, called brexpiprazole. It's an antipsychotic medication, and maybe in the Q&A we can get into all of that. Next slide. These are the three buckets I mentioned before, so we can just go to the next slide. All right. So those behavioral and psychological symptoms are prevalent. They're associated with cognitive and functional decline. They distress patients with the illness and their caregivers. And that's one of the domains of the symptoms that we try to target. The other domain are the cognitive symptoms themselves. And although the slide is titled Treating Cognitive Symptoms, because that's what these drugs are approved for, they also do have an effect on behavioral symptoms, including apathy and sometimes hallucinations. So back in 1993, so 30 years ago this year, the first ever drug approved by the FDA for Alzheimer's disease was approved. It was called Tacrin or Cognex. It's actually no longer on the market because of toxicity and 4 times a day dosing and other side effects. But now we've got 3 other medications: donepezil, rivastigmine, galantamine, otherwise known as Aricept, Exelon, and Razidine. Those have now been on the market over the past 20 to 25 years. What those drugs do is what they do not do is they do not attack the underlying biology of Alzheimer's. They don't attack those plaques and tangles. But what they do is that they often will attack the chemical changes that happen downstream, like a reduction in acetylcholine levels, or another medication called memantine, which reduces a toxic chemical in the brain called glutamate. So today in 2023, the standard of care for Alzheimer's type dementia, and frankly for many other dementias, is to prescribe one of the cholinesterase inhibitors, like donepezil, along with memantine together, because the two seem to work better than either one alone in slowing the decline, not in reversing the underlying pathology. Next slide. Moving towards where we are now with new therapeutics is really starting to address the underlying pathology. So this is new research that's been now probably 2 decades in the making. And hats off to my colleagues in the basic neurosciences at the NIH and certainly in the pharmaceutical industry for bringing these drugs finally to the point where they're now going to be available for people in clinical care settings. So basically, as the backdrop to this is we have amyloid in the brain and we have tau in the brain. Those 2 proteins make up the pathology of Alzheimer's. In order to slow the loss of brain cell tissue over time that causes the symptoms of dementia, the theory is, the amyloid hypothesis theory is, let's get rid of the amyloid. And we do think that there's a link between amyloid and tau. So let's get rid of the amyloid, which may then reduce the buildup of tau, which then may reduce the progression of the illness. So all of the targeted therapies I'm about to tell you about, or at least a couple examples, are either reducing the buildup of amyloid in the brain, or once it's there, dissolving it and removing it from the brain. Both of these types of proteins can be seen in the brain using a technology called PET brain imaging. So we can inject a radionucleotide into your vein in your arm. It goes up into your brain and it lights up in a scan, and you can see the areas which light up. So the next slide, I think, shows what this looks like. The first drug that was approved by the FDA for the treatment of Alzheimer's disease was called aducanumab, is called aducanumab. It's the Biogen drug that got a lot of press, a lot of controversy a couple of years ago. And the reason it got approved was not because of its ability to slow progression of the clinical symptoms of memory loss and functioning, but because it could do what you see on the right side of the slide here. So if you look at those top 2 brain imaging slices on a PET scan, the red is amyloid, and areas that have no red are free of amyloid. And on the left column, you see patients who are at baseline before being given this drug, this amyloid removing drug called aducanumab. And the vertical lines are placebo, which means no drug, just the saline infusion. And 3, 6, and 10 are the doses of aducanumab. And what you can see pretty clearly is that after a year on 3, 6, and 10 milligrams of aducanumab, and certainly at 10 milligrams, you completely remove amyloid. So the FDA made a decision, a very controversial decision in January of 2021, or was it in the summer of 2021, 2 years ago now, that they were going to approve this drug, not for the clinical symptoms, but under a pathway called accelerated approval because of its ability to remove amyloid. That caused a lot of controversy. We can talk more about it. Next slide. And then this drug came along. This drug is called lecanemab. It's a similar antibody therapy that is infused into the vein. This one happens to be infused twice a month. People come into the infusion center for an hour-long infusion visit. The infusion happens over the course of an hour. We get PET scans before and after treatment, which usually is at baseline and 18 months later. This is the well-known now Clarity AD trial. On the day it was published by the New England Journal of Medicine, this was the day that the results were released and the FDA granted what was called accelerated approval. It received full clinical approval in July of this year. It was an 18-month study, and for the first time ever, a study like this was completed, and at its primary endpoint at 18 months, it showed a clinically significant change, statistically significant change in cognition and functioning, about 27% difference in people on drug versus placebo. Now, what were these measures anyway? And what does 27% difference mean anyway? Let's talk about that in the Q&A, because I think it's important to put in perspective what this means, what this might be able to do, but what this is not going to do. But this is the first real advance we've seen in Alzheimer's treatment in 30 years. Now, there is a downside to these drugs. There's the time and the cost, of course, but there's also brain swelling and brain bleeding. And those are the rates that you can see here. About 17% get small mini hemorrhages and about 12.5% get swelling. Now, the question is, well, what do these mean? And essentially, they're seen on an MRI scan, so we know they're there. But very often, they don't even cause symptoms. So it's important to know what they are. but it's also important to put them in the context and perspective. There are risk factors who gets this, and there are ways to reduce the risk of getting this side effect, which we can talk more about. Next slide. Before I move into the healthy brain aging part, I just want to talk about a program that Chris and Gabrielle, who's on this call, and possibly others who are on the call. Barbara was involved in this in the early days. We launched this program in 5 primary care practices in the Mass General Brigham system, beginning in the winter of 2020. So we had impeccable timing, right as the pandemic was breaking out. We had sites at Mass General, at Newton Wellesley, and at the Brigham. And we built this model based on our colleagues at UCLA who developed the Alzheimer's Dementia Care Program, the ADC program. And we were part of a pilot study they were doing. It just so happened that we chose their model, and they were at that time funded by the Hartford Foundation to do the study. And we implemented it in these 5 practices with a team that included a dementia care manager who was a social worker like Chris, a geriatric nurse practitioner like Gabrielle, and a supervising geriatrician. And that team would care for upwards of 300 patient caregiver dyads over the course of a year, and were in frequent, regular contact with primary care providers, and it basically intervened with the 6 boxes you see on the bottom left, but a lot of services that anyone with dementia and their families would want that now exists within the primary care setting. Assessment, stratification of risk in terms of risk for being in the hospital or risk for having behavioral symptoms of dementia with a bad outcome, disclosing the diagnosis, talking about serious illness, planning for the future, talking about how best to support the family members during this dementia care journey, how best to get rid of medicines that might be causing problems or adding medicines that might help, and then very importantly, to navigate resources in the community, whether it's day treatment programs or long-term care programs or other things that could benefit both the individuals with dementia and their loved ones. Next slide. We also then realized that there was a cohort of people who may have benefited from a different type of intervention. And essentially, the reality is that the last model I just told you about is expensive. Those are a lot of clinical personnel to put into a practice. And so we were looking for other models that might be scalable. And we came across our friends at UCSF with a care ecosystem model. And my partner at MGH, Christine Ritchie, and I helped to develop this model within our care management programs that we launched through a grant from the National Institute of Aging. And we studied outcomes, including how likely was it for the person who was being cared for by this nurse care navigator to go to an emergency room versus someone with dementia being cared for by another nurse who didn't get the intervention. And so we have looked at that data, and we're publishing that right now. I'll just mention that in July, just about a month ago, the Center for Medicare and Medicaid Services, CMS, finally launched a alternative payment model that would support this kind of intervention, dementia care management, essentially, as part of a payment mechanism for people with dementia and families. Because prior to now, there was no way to reimburse for these services, essentially. There was one code that got underutilized and wasn't well reimbursed. So there now may be an opportunity to utilize a innovative payment model, if you can imagine, from Medicare to help support this type of work. And it wasn't an accident that they came out with this model. They had a lot of input from evidence-based programs like this one. Next slide. These are the different protocols that we utilize in care ecosystem. Again, we call our program here Crescent, and you can sort of read them on the slide. Next slide. So over the years, as I was caring for so many people with dementia and their families, I found myself repeating myself a lot about, like, well, what would I do if this were me or my family member? Or what are some of my lessons learned in caring for people? Where are the biggest pain points and challenges along the dementia journey? And I thought one day, I just wish I had something to hand people. And so Tom Harrison is a journalist who had worked with a colleague of mine at McLean on a book for substance use disorder for families. And he had a mom with dementia. And he learned a lot by caring for her. And he found me through my colleague, and he wanted to know if I'd be willing to collaborate on getting this book to be published by Guilford Press. And so that's what became our Complete Family Guide to Dementia, which was published last summer. Next slide. And I just want to make a couple points that come out in the book, which I don't think I've really seen written about elsewhere in the way that we portrayed it. And I really give Tom all the credit because I think it was his singular insights about what it was like to be an adult child caregiver and some of the nuances of dementia care that is so different than heart failure care or cancer care, or any other medical disease state care that I think we really try to highlight in the book. So a couple of things that we highlighted is how is dementia different and why do families make some of the same mistakes over and over again? And one of the ways in this is different is that, there's a lot of similarities with normal aging, like what's normal and what's disease. We talked about that before. And it doesn't always whack you over the head right away. It builds up over time. It's gradual and it's progressive. And when you see a loved one, an aging parent or a spouse or a sibling who's got challenges with brain function, there's a lot of denial and minimization. Well, maybe they'll be fine. Or maybe it's just a bad day, or maybe they're stressed. And the person with the illness may be terribly frightened and may not want to do anything about it. So these defense mechanisms are commonly employed, and they lead to a delay in making a diagnosis. We don't have the urgency always. It's not like someone has an immediate heart attack and everyone's mobilized, or they get a diagnosis, a biological diagnosis of cancer, and there's a whole cancer center to take care of them. We don't have that in dementia care yet. The medical community, as I alluded to before, is not adequately educated or supported in making these diagnoses or developing effective treatment plans. And as I mentioned already, there's massive fear and stigma. Next slide. So we urge, and I think this is just general clinical, makes sense stuff to me, is instead of, how do you tackle a problem as complicated as dementia? I think it's about being proactive and not reactive, and how to care smarter and not to care harder, which means that there are a number of things that we have to think about preserving ourselves as care partners and caregivers in this whole course of illness. So one is we need to understand that the nature of our relationship with family members will by definition inherently change, especially if we're an adult child. Well, even if we're a spouse, it really doesn't matter what the relationship was before. It's going to be different in the setting of dementia because as the person experiences these brain changes, the nature of their interactions will change, their priorities may change, their personalities, the way we describe them may change a bit. So the relationship also changes. That's hard, that's challenging. So we need to be proactive and to expect that. I think it's so important that we focus as family members on loving and caring for our family member. And when we are there to provide medication management, taking people to appointments, doing all the care management stuff ourselves, it's very hard to just be there for your loved ones and to care for them because you're involved in all the nitty gritty. And that's where social work care managers are more than worth their weight in gold. And unfortunately, our healthcare systems up until today really don't have equity in terms of funding that type of service. I think the guide model is the first time I've seen the government try to step in with that type of intervention. We also need to understand that dementia involves a prolonged period of grief and mourning. This is a long journey. And when someone is at the end stage of illness, they're often someone that you don't recognize from when they were, earlier in your life together. And so although when someone passes away, there's grief and mourning, it's often that it's been going on for years. And we have to recognize that because sometimes our reactions to our loved ones in the heat of caregiving reflect our own grief and our own distress and our own losses. And then finally, this is so much easier said than done, but I can't tell you how many caregivers I've seen that wind up dying before their spouses with dementia, not just getting sick, but dying, dead. And I've warned people that unless they can take a step back and ask for help and take a break, they're at risk of dying sooner. I've had numerous caregiver spouses who have had heart attacks while caring for their loved one. So I don't say this to be inflammatory, it's just, it happens. So part of what we need to think about in healthcare is that our patients in the context of dementia care are not just the people with dementia, it really is also the whole family system. Next slide. And then we need to make a plan for caring. And this is where there's a lot of opportunity to think about approaching the common challenges, which are really hard. We talked about behavioral and psychological symptoms. But driving, like when should someone stop driving? How do we know it's time? Who's the bad guy in saying it's time to stop driving? There are all sorts of ways to approach this that we talk about in the book. And then making sure, especially early on in the illness, that the person with the illness is expressing their wishes about what they want at the end of their life. How aggressive do they want to be? How non-aggressive? What should it look like? And then finally, something that families usually want to avoid because mom usually said, or dad said, or someone said over the years, well, the last thing I want you to do is put me in some type of institutional setting or nursing home or an assisted living or whatever. And I think it's important that we recognize what we can do in the home environment and what we can't do. And some people with dementia can be cared for just fine at home and sometimes not. But understanding what the options are out there, how to pay for those options, we go through all this in the book. All right, next slide. Finally, my approach with dementia, I have to say, is remarkably proactive and positive as opposed to reactive and negative. I like to think about what we can do despite dementia as opposed to what we can't do. And then this also comes into the play in terms of our aging brain, whether we are in our 30s or 40s or 50s, or whether we're older and we already have a cognitive problem. All of these principles apply. So I'm going to go through these kind of quick because I want to have time for Catherine and then time at the end. There have been a series of studies summarized in this report by the Lancet Commission 6 years ago that highlighted modifiable risk factors for the development of dementia at various stages of the life cycle. And if you look at these variables on the slide, early in our life, in our midlife, and in our later life, all of these are modifiable. None of them are genetics or age, which are not modifiable, at least now. So if you look at risk factors when someone's younger, we know that lower educational levels predict higher risk of dementia later on in life. We know that in midlife, hearing loss, interesting one, we could talk more about why, biologically, possibly also social connectedness related, hypertension and obesity, and then later life smoking, social isolation, physical inactivity, diabetes, depression. All of these have been identified as modifiable risk factors of dementia. And if we obliterated these from the globe, we'd prevent about a third of all dementias today. It's pretty amazing, actually, if you think about it. If you look at all of these variables, almost every one of them is associated with heart disease risk and stroke risk. And we've now known through the Framingham Heart Study and years of research that by getting people to stop smoking and to treating diabetes and to keeping people physically fit and watching their diet, we're eliminating a lot of risk for heart disease. We can do the same for dementia. Next. So my colleague and friend, Dr. Jim Ellison, my former boss at McLean, who no longer is at Christiana Care, but was most recently, came up with this acronym, which I like to talk about, called DANCERS. Next slide. So we broke down the acronym of cognitive aging, healthy cognitive aging, into these essentially 7 steps: disease management, physical activity, nutrition, cognitive stimulation, engagement with others, relaxation, and sleep. Next slide. We went through this already, but if you look at this slide, this is a whole host of medical disorders that can contribute to the risk of dementia or adversely affect cognitive functioning with advancing age. And we can intervene, and we'll talk more about the bolded ones through the cardiovascular risk factors. Those are all cardiovascular risk factors that are also dementia risk factors. Next slide. Of all the data I've seen in terms of healthy brain aging, the probably most potent are in the categories of physical activity and nutrition. But with physical activity, the benefits of exercise are amazing. We know about its effects on medical issues like cholesterol and blood pressure and obesity and insulin sensitivity and modulating blood sugars and things like that. We also know it improves balance and reduces risk. But moreover, it also seems to stimulate new brain cell growth and improves mood. And it doesn't have to be training for a marathon. It can be 20 to 30 minutes of aerobic exercise 3 or 4 times a week, where you get your heart rate up. You can do stretching, you can do yoga, you can do strength training. All of these interventions are helpful. Next slide. I am not a nutritionist, and I don't pretend to be one, but I have looked at this literature. And the Mediterranean diet is an excellent example of factors that promote healthy brain aging. Essentially, what we're talking about are nutritional interventions that reduce the effects of oxidative stress on the brain and of inflammation in the brain. So, the main dietary fat is olive oil, and it focuses on vegetables and fruits and essentially omega-3 fatty acids through fish, and really moderating, if not eliminating, red meat, etc. Next slide. There's also the mind diet. We can go to the next one. The third factor is keeping our brains active as well. Now, some people love crossword puzzles, and that's great. Some people are really bad at crossword puzzles, and that's frustrating. So it's really not one size fits all. But there was a lot of research that's been done about cognitive stimulation with the maintenance and improvement of cognitive functioning, both in animal studies as well as in human studies. And this is also where we see people who have excelled in their lives educationally and excelled from an occupational standpoint. They have this tremendous amount of cognitive reserve. So it takes a lot of degeneration of brain tissue to show the signs of dementia in folks like this. Next slide. Another factor that is critical is social engagement with other people. Social isolation, we know, is a risk factor for health decline, and it's a risk factor for dementia and cognitive decline. We know that engaging with people who you care about as friends, family members, etc., will improve our immune function. It will reduce inflammation. It will improve probably overall not only brain function but also mortality. Next slide. And this is how it helps, I just said, but it's also, it's kind of remarkable when you think about it. We had an epidemic of loneliness and isolation, especially in the first year and a half, 2 years of the pandemic. And we started seeing a lot of stories in the press and in the literature about the adverse impact of social isolation and loneliness. And there's a lot of data to support that. Next slide. I like to practice what I preach. And so far, I'm really good with all the things I just talked about. And I'm really bad with this. Not that I can't sleep, I just don't sleep that much. And I think it is problematic in terms of brain function. I think we're seeing over time the adverse effects of poor sleep on the risk for amyloid buildup and inflammation and our effects on concentration in our daily life. So if there is a sleep disorder like sleep apnea, restless leg syndrome, we need to identify it and treat it. Next slide. These are the consequences. We've also seen not only a reduced quality of life, but also a shorter survival based on sleep quality. Next slide. Harvard put out this great guide to cognitive fitness that really talks about all of these principles that we talked about. It talks about how to build cognitive reserve, and it's available online through Harvard Publishing. Next slide. All right, so I'm going to turn over to Catherine in a minute, but before I do, I just want to summarize that diagnosis of dementia is possible in a primary care setting. And as we develop more and more of these disease-modifying therapies that could alter the course of illness, we need to use them early stage illness. They won't work too late in the game. So as we start to see more opportunity for prevention and early intervention, we got to get better and better at diagnosing earlier and earlier. The current treatments that we have for dementia now will help with all the domains of dementia, cognition, function, and behavior. And our goal at the end of the day is quality of life while also maintaining safety, and to work with people with the illness and their loved ones to try to come up with a care plan that everyone's on board with. So in the last few minutes, next slide, Catherine, I'm going to turn this over to my colleague, Catherine Turner. Catherine was a student in college when I first met her at Haverford, and she was a very promising, well, at the time she thought pre-med, and she's been helping me for 2 years with clinical studies at McLean and now at Tufts. And she's going to describe a couple of the studies that we're doing now at Tufts and at McLean that some of you may or may not want to participate in, and we have some contact information for that. So Catherine, take it away.
Hi, everyone. Can everyone hear me okay? Okay, great. So thank you for that very sweet introduction, Dr. Forester. Looking forward to talking about 2 of our ongoing research studies. Before I do, I'd like to highlight that, participating in research represents a great opportunity to contribute to Alzheimer's disease research that we hope can be beneficial to you now or to people with AD in the future. It also offers an opportunity to interact with our amazing research staff. And if you are a loved one or is interested in getting involved in our research studies that I'm about to discuss, I encourage you to reach out to me directly after this talk. I'll put my email address in the chat when I'm done speaking. So the first study that I'd like to talk about is our THC-AD study. This study is focused on managing the behavioral symptoms of Alzheimer's disease. This study is a 3-week placebo-controlled, double-blind, randomized clinical trial of dronabinol. Dronabinol is a synthetic version of THC, and this is a study in older adults with Alzheimer's disease that also have severe agitation. And I'll just note that a double-blind placebo-controlled trial is where there's a 50% chance that a participant gets the study drug and a 50% chance that they get placebo. This study consists of 5 in-person visits over the course of 3 weeks, so it's a relatively short study. A little bit of background of why this research study is being done. We're conducting this study to determine whether dronabinol is an effective and safe treatment for agitation in Alzheimer's disease. As Dr. Forester mentioned earlier in this talk, agitation in Alzheimer's often includes combativeness, yelling, a lack of cooperation with care, insomnia, and restlessness. One or a combination of those symptoms can lead to great caregiver burden and a shortening of the time to institutionalization. As Dr. Forester mentioned, that second bullet point that there are no FDA-approved treatments is actually inaccurate, as brexpiprazole was approved in July of this year, but that is currently the only FDA-approved treatment. And lastly, in recent years, researchers have found dronabinol to be a useful treatment for agitation in Alzheimer's, and our study is looking to validate these findings. You may be eligible for this study if you're between the ages of 60 and 90 years old and have a diagnosis of probable Alzheimer's disease and are experiencing symptoms of agitation. The second study that I'd like to talk about is focused on brain metabolism, which relates to brain energy. So as we know, our brains have a very high energy requirement, meaning it needs a lot of energy to perform all of the complex daily tasks that we use our brain for. It's increasingly thought that deficits in the brain's ability to produce and use energy play a critical role in aging and the development of Alzheimer's disease. So we call this study NRAD for short. This one's looking at the effects of orally administered nicotinamide riboside, or NR, on bioenergetic metabolism, oxidative stress, and cognition in individuals with mild cognitive impairment and mild Alzheimer's disease. So this is a 12-week clinical study of nicotinamide riboside, which I call NR for short, it's easier to remember, which is a safe over-the-counter oral supplement that plays a role in metabolism in the body and the brain. So this study consists of 3 in-person MRI scanning visits over the course of 12 weeks. A little bit of background of why this study is being done. We're conducting this study to analyze the effects that NR may have on the brain and to see how those changes may result in improvements in thinking and functioning. Lastly, dysfunction and deficits in the brain's ability to produce and use energy are thought to play a critical role in Alzheimer's disease. Therefore, NR, the study supplement, may improve brain energy metabolism, thus potentially resulting in improved thinking and cognitive functioning. For this study, you may be eligible if you're between the ages of 55 and 89, and if you have a diagnosis of mild cognitive impairment or mild Alzheimer's. So that's just a brief overview of our currently enrolling research studies. Like I mentioned before, if you would like additional information or to get in contact with me or someone from our research team, I'll put my email in the chat and you can feel free to send me an email. And just like to highlight again that our studies do represent a great opportunity for you to contribute to research. And many participants really enjoy coming in and spending time with our research team, as well as being under the clinical watch of our amazing clinicians.
Thank you, Catherine. That was great as always. So we could probably take down the slides. And Chris, you want to begin with moderating and we'll go from there?
Sure, absolutely. So give me 1 second. I'm going to make sure everybody can see us. All right. So thank you so much, Dr. Forester and Catherine, for your presentation. I'm very interested to see what our participants have in terms of questions. So the way this will work is I'm going to go down through the chat here, and if you have a question, please put it down there, and I will ask it to both Catherine and Brent, and we will get through as many as we can with the time that we have allowed. We have about 35 minutes or so. So let's get started. So the first question I have on here comes from Ellie, and Ellie asks, what was the outcome of the CBD study at McLean? I don't know if you're familiar with that, Dr. Forester.
Oh yeah, I'm familiar. We started that study. Thank you, Ellie, for your question. So we are partnering at McLean with one of my colleagues named Stacy Gruber, who is a world's expert in the use of cannabinoids for the treatment of psychiatric conditions, including anxiety and depression. And we were approached a number of years ago by a gentleman who was supporting some of our research, who had a dad with dementia and was quite agitated, and found just anecdotally that, essentially medical marijuana was quite effective in treating his dad's severe agitation towards the end of his life. So this is Greg Spire. He's been very public about this in the media. He's supported a lot of our research. So Greg and his family foundation supported us to do what was called the CBD trial for anxiety in people with Alzheimer's disease. So we are still recruiting people, Ellie, people with the probable Alzheimer's disease who are still living at home with loved ones. And it's essentially a 12-week study of a cannabidiol product for anxiety and Alzheimer's disease with an extension that lasts for up to a year. So it's still ongoing, and as soon as we get results, we can't wait to show them to the world. But this is very early stages, and I'll just say that the CBD study that you just asked about and the one that Catherine just described, which was with another cannabinoid called THC, this work is really early stage. And yet the reason it's so promising is because the beneficial effects might be quite notable with much fewer of the side effects that we see with some of our psychiatric medications that we're using now. So thanks for the question.
All right, fantastic. All right, and then our own Judy Willett asks, have there been studies on how brain injury is connected to dementia?
So thanks, Judy. So there's a huge literature on this, and there's a group at Boston University here in Boston that's done a lot of work on the relationship between traumatic brain injury and dementia. People are probably well aware of the resources that the NFL, the National Football League, has put into some of that work as well. So there does seem to be a relationship between traumatic brain injury and a specific kind of brain disorder that's called CTE, or chronic traumatic encephalopathy. The protein deposits that are related to that illness look more like a tau disease than an amyloid disease. This is really new information that we're learning about more all the time. And we don't really have a singular early biomarker to detect who's the risk of getting it or how to track it over time. That's why these longitudinal research studies are so important. So I think there's definitely a risk. One thing I'll say, though, even absent the tau issue and CTE, people who have had repetitive head injuries are at risk of developing dementia when they're older. And it could have been an earlier in life head injury as well. And we don't know if that's because of a flood of amyloid that builds up and then it's sort of dormant for a while and then progresses over time. But that relationship is certainly there, and we just need to understand more about its link and how to prevent, progression.
Okay. Let's see here. So the next question is Nancy. Nancy asks, there's a couple parts to this. How do you assess for getting names, where to put things, or I'm losing things, etc., as aging versus dementia? So how do we determine what constitutes normal aging with what could be warning signs of a dementia spectrum disease? Is there relevance to analytic ability if it remains strong? And finally, is slow retrieval, memory retrieval, a sign of dementia or as an effect of more stored information as we age?
Nancy, I think you might be a clinical neuropsychologist with such astute questions. So there are many pieces to your question, and luckily I have it in writing next to me here. So the first thing I'll just say is that when someone has a hard time recalling familiar names or where they put things, there are a couple of considerations. One is it all the time? Is it only when under stress or sleep deprived? Is it getting worse? Is it about the same? There are all sorts of aspects that we would want to investigate. But most importantly is we would want to do objective testing and figure out, what is this? And without the objective testing, like the MoCA I showed you, or further detailed cognitive tests like a neuropsychological battery that could take 2 to 3 hours. Without that detailed testing, we have no idea if this is normal aging or a memory disorder like dementia. So that's why I make a huge pitch to get effective cognitive comprehensive assessment to figure out this differentiating normal versus disease state. Even with the detailed testing, sometimes it's hard to tell. Sometimes we just know what you're like today, and it's, September 12th, and we'll follow you again in 6 months or a year. And if it's about the same or better, that's good to know. And if it's worse, that's also good to know. But it's the serial testing over time that can also provide some guidance. Now, you asked specifically about analytic ability. I guess I'll lump that in a cognitive function we call executive functioning. Insight and wisdom is part of it too, perhaps. But there are some cognitive functions that get better with aging, like wisdom and perspective, and some things that do get affected by disease and with aging called executive functioning, like organization, planning, decision-making, multitasking. Again, we can tease that apart with detailed testing. And then you specifically asked about retrieval, slowing retrieval. That is definitely a hallmark that we see in people with stroke, with depression, and sometimes just with normal aging. In other words, people are given, say, 5 words to remember, and then 5 minutes later, they can't come up with a word spontaneously, but you give them hints and reminders and cues, and they get it just fine. That's a memory retrieval problem. It may take longer for them to get it, but they get it because they stored the information. In Alzheimer's disease, you can give people all the hints and the reminders in the world, and it ain't there because it was never stored. It's a memory storage problem. It's a very different type of problem than a retrieval problem. So that's a little subtle difference of a memory problem, retrieval versus storage, that we can tease out with a really simple test. But it's not just a casual conversation with a loved one, and it's not just a casual conversation with your doctor. It's really doing these tests to figure out what's normal, what's abnormal, and then to track it over time.
All right. And so our next question comes from Jim, and Jim asks and I'm probably going to butcher this word here, is nicotinamide related to tobacco chemicals?
So I think you're referring to the nicotinamide riboside that Catherine just talked about in our study. And it's actually not tobacco. It's not nicotine. It's actually a vitamin B complex. It's an over-the-counter vitamin that you could pick up at the local, drugstore or natural food store. So it is not, it's not nicotine. However, there are 2 types of cholinergic receptors in the brain. Nicotinic receptors is one of those types of receptors, and stimulating nicotinic receptors can help with attention and memory. It's one of the reasons why people like nicotine, because it helps them focus. But unfortunately, it's wrapped up in all the bad things that cigarettes contain. So it's toxic and causes cancer. It turns out that the medicines I talked to you about in the study stimulate cholinergic transmission, and one of which stimulates nicotinic receptors in the brain specifically, and that's galantamine or razidine. That's a subtle point there. So, but just for Jim, so nicotinamide we were talking about is a vitamin B complex that is not nicotine.
Okay. The next one that we have Mr. Walter, and he asks, are there any studies regarding Haldol and its effect on dementia?
Whenever people ask about a drug, I always want to know why. So my guess is, Walter, there was either a really good or really bad outcome when someone you knew was given Haldol. So Haldol is an older generation antipsychotic medication. It was developed in the 1950s and 60s in the United States. It's been approved for the use of the treatment of schizophrenia now for decades and decades. It has been studied extensively in Alzheimer's disease and other dementias, but not in a randomized controlled trial, probably since the 70s or 80s. All the data we have on the use of haloperidol for agitation or psychosis and dementia that's recent comes from large meta-analyses of huge databases at the VA or in other healthcare systems. And the problem with Haldol in older adults is that older adults with dementia in particular are exquisitely sensitive to the side effects of Haldol. And the only time Haldol should be used in older adults is in a truly emergent situation that requires intravenous administration of an antipsychotic or an intramuscular injection where nothing else is working because there's an acute safety problem. The problem with Haldol is the adverse effects linger for days sometimes. So people who develop these confusional states called delirium, and we wind up having to wait days on an inpatient unit to see what someone's baseline is because the Haldol been so disruptive to their brain function. I would not think of this as a first-line treatment or a 10th line treatment. It's more of a desperation treatment when nothing else is working. I know that sounds a little bit harsh, but I would really try to avoid Haldol.
Okay. Our next question comes from Laura, and Laura asks, is someone in the early or moderate stage of dementia a possible candidate for lecanemab?
Thank you so much for asking that question, because I did not dwell on the inclusion criteria for lecanemab. So why don't I say that now? So the early days of the anti-amyloid therapies, of which lecanemab is one, we didn't know when in the disease stage to intervene. So we, in the scientific community, were developing these trials for people all the way through the moderate stage of illness where someone can no longer drive or pay their bills. And by doing those studies, we realized that regardless of the drug, if you start too late, they definitely do not work. Now, if you start early enough, they still may not work, but if it's the right drug with lecanemab, they do seem to be helpful. So the two disease states where lecanemab is approved is in the mild cognitive impairment form of Alzheimer's disease, which is memory loss without functional impairment, or very, very early Alzheimer's type dementia, where there's memory loss or other cognitive changes plus a little bit of functional impairment. And that little bit of functional impairment is very much specified on a rating measure that will be used in clinical practice to see if somebody meets criteria or not. And the FDA was very clear about who it was approved for and who it wasn't approved for. And my guess is formularies and hospital systems and insurance companies that pay for these drugs are going to be very specific about who's going to have access and who won't. You don't want to start a drug that's costly with side effects in a population that we know won't benefit. So MCI and early Alzheimer's.
Okay. Hope that answers the question. And so our next one is, do you recommend a lumbar puncture to get a definitive Alzheimer's diagnosis? And if so, how can this be done within a primary care approach?
So let me address the global topic of biomarkers, and then I'll talk about lumbar puncture in particular. So biomarkers give us a sense of what's going on in the brain's biology, and there are three ways to see the amyloid and tau biomarker of Alzheimer's. There are three ways. We can see it through amyloid and tau PET imaging, which I showed you that picture where it lights up. It's an imaging study. It's extremely non-invasive, and it's extremely expensive, and to this day, no insurance pays for it. It's only available in research studies. On the other end of the spectrum is a very inexpensive, easily accessible brain biomarker that's collected through a lumbar puncture or a spinal tap, where we can measure these proteins in the cerebrospinal fluid. It's easily accessible. It's very inexpensive. It's paid for by insurance. And yet, have you ever met anyone in the United States who wants to get a spinal tap? There's something about the culture of spinal tap in our country compared to Europe, where it's way more acceptable for whatever reason, by the population at large, but also the medical community. So for the early, for people now going into the lecanemab clinical treatment, that's going to be the most likely way that the data is going to be collected about biomarker status until we have insurance to pay for the PET scans, which may happen, by the way, in the near future, but right now it hasn't happened. Now there's the third way, and this is the most promising way. This is essentially going to allow us to have, if you will, a blood-based biomarker for Alzheimer's disease, where we can measure in your blood plasma the amyloid plaque that is reflected in your brain by getting, or the tau in your brain by getting a blood-based biomarker. These are in their research stages still, but once they're approved because of the definitive data that they're highly correlated, it's going to be easy to collect, it's going to be inexpensive, and it's going to be highly correlated with disease state and progression over time. That is the holy grail of biomarkers. And once that's out there, it will change everything in terms of diagnosis. Now, that alone will not make a diagnosis. It will provide a risk factor. You'll have to do other things as well, but that will be required, just like now we're going to require some biomarker to be a candidate for any of these new therapies. And within a primary care setting, I've not met any primary care doctors that would do an LP. Now, if they happen to have a neurologist in the practice, yes, they would do it. If they train their nurse practitioners who are awesome at this once they're trained, they would have it there. And if we need to really scale LPs, we're going to probably have to go out of outside of the typical neurology community to be able to do enough of them. But right now, it's not going to be ordinarily available within primary care. They could order it, but the test would be done by other providers.
Yeah. It sounds like blood tests would absolutely supercharge the early detection of dementia. At least starting the conversation at way earlier stages if we're able to detect it in the blood rather than having to rely on when symptoms emerge. So,
Chris, I would agree. And I would also add one other fine point to this. If, let's say, 5 years from now, we have a blood-based biomarker that at the age of 50 or 60, you could see whether or not you had the disease in your brain, but you had no symptoms whatsoever, would you want to know? Mm-hmm. And one of the questions is, well, I guess I would want to know if I could do something about it. And then the question is, well, what could you do about it? Well, all the things I talked about in healthy brain aging, we should be doing anyway, whether you got the biomarker or not. Okay, that's number one. But number two, if we find out that lecanemab helps people in that on that slide I showed where the graph went down, in the dotted line versus the solid line, if we intervene with lecanemab in preclinical stage where you got the blood biomarker that says you got amyloid in your brain, but you're functioning fine with normal memory, if we found out that lecanemab intervention then, or one of these other treatments in the future, could prevent the development of MCI and dementia, we would also want to know. So I think very soon, just like in cancer now, think about, by the way, the analogy with cancer is amazingly, there's a lot of overlap. There's a lot of differences, but one area of overlap is in cancer care today, there are all sorts of biomarkers that were getting collected to prevent the progression of cancer or any of the symptoms from occurring in the first place or to treat it. Whether it's mammography, whether it's a blood test, whether, there are all sorts of pap smears. There are all sorts of biomarkers that we collect for cancer detection and to follow how treatment's going. That'll be what Alzheimer's disease looks like. The other thing with cancer care today is that we now know that cancer is heterogeneous. There's so many, it's not just based on the tissue where it started, like in the lung, but it's based on the genetic markers of the cancer. So the biomarkers get infinitely complex, but the therapies get more and more targeted, which means people are living longer. That's going to be what Alzheimer's disease looks like. We're going to see a cancer care model for Alzheimer's disease over the next decade plus, both from a biological standpoint as well as a care delivery standpoint, so that we're able to deliver holistic dementia care for people with the illness and to support their families. The other thing I'll say with cancer care is, finally, our oncology friends woke up over the past 30 years and realized you can't just treat people with toxic drugs and not support their emotions when they go through cancer. And now psycho-oncology is a huge field in psychiatry. You don't see a cancer center that does not address the needs of the families or of the people with the illness. So even with amazing biological therapies one day for Alzheimer's, we still got to take care of the whole person and their family. Thanks for letting me go off on that, Chris.
Not a problem. Not like I could stop you anyways. All right. So the next question comes from Joyce, and it's actually a question that I've had holding in my mind. What new meds approved can be used for those diagnosed with FTD? And what I want to add to that is, do you know of any trials or any work being done to address other dementia spectrum diseases, things like frontotemporal dementia, basicortical degeneration, aphasia, Lewy body? Is there any work being done in those areas? I know we've been talking a lot about Alzheimer's specifically, but as we know, there are many types. So is there any work being done for those?
So the first thing I would say is that the rest of the dementias have been not ignored because they're not important, but because the Alzheimer's disease itself is just so common. And so from a the standpoint of, population health need and investment, I think that's why Alzheimer's disease has been the primary focus. However, the two areas where I think there's a lot of promise, but not yet enough drug development, is in Lewy body dementia and in frontotemporal dementia. These are two very devastating forms of dementia. They're all devastating, but these two in particular are really difficult to treat because the behavioral symptoms are so pervasive and they're so impactful in terms of functioning and quality of life. The one drug that's on the market now for Alzheimer's that also has another approval is rivastigmine, which is Exelon, for Parkinson's dementia. There's a lot of overlap between Parkinson's and Lewy body dementia. And if you look at the studies of rivastigmine and the others for Lewy body dementia, you'll find out that there actually is some evidence for benefit of rivastigmine for Lewy body dementia. It just doesn't have the approval yet. So I actually think that all the cholinesterase inhibitors, even though it's off-label, except for that one example I just mentioned, probably help every other form of dementia except for frontotemporal dementia. That's where we've seen no benefit. Brad Dickerson at MGH, who you know well, is one of the world's leaders in frontotemporal dementia research. Some of these dementias have their own organizations supporting them, advocacy organizations, the Lewy Body Dementia Society, FTD, et cetera. I think the FTD and Lewy body are the two areas that are ripe for developing biomarker-specific targeted therapeutics. We're just not there.
Great, thank you so much. A question I had, very briefly, is we were talking earlier before, or you mentioned before, when some of the first drugs, we're talking about the donepezils, the memantine, rivastigmine, were first introduced onto the market. It was quite some time ago. It was about 20 plus years ago. Is there any reason that research into Alzheimer's disease in particular has taken such a long time to produce, a significant, I would say, I guess, upgrade or development in terms of an available treatment? It seems like there's been a large gap in terms of what treatment is available versus what's being worked on.
Yeah, so Chris, that's a really good point. The first therapeutic on the market was actually 30 years ago in 1993. And that was decades of research in the making with all these drugs that enhance cholinergic transmission in the brain. Those are the Ariceps and the donepezils of the world. Memantine, which had been developed first in Europe, then came along in 2003. And then we had a 20-year, essentially, period of nothing. Nothing, no new therapeutics. Not that they weren't being developed, but that they weren't yet readily available. And I think why there are two reasons why there has been such a gap. And this is my own personal perspective. I think one reason is this is a hard problem to solve. This is the amyloid theory kind of grew up in the 1980s. The genetics of Alzheimer's disease was being done in various centers around the country. But it was really a tricky target, and how would you develop the therapies and get them into the brain and all of that. But the major reason why the development was so slow is because of underfunding at all levels. Disease treatment of diseases progresses because of advocacy. And if you use HIV as a great comparison, when the HIV epidemic hit in the 1980s, 1979 first, but 1980s in the United States, the advocacy efforts were unbelievable and continue to this day. And when I was in my internship at MGH 31 years ago, all of my HIV patients developed AIDS and they all died. And the first therapeutics were coming on the market. And within 2 years, Magic Johnson gets AIDS and he's still alive. And it's amazing to see. So they had, like 10 years ago, there were about 1 million people in the United States with HIV, and we were spending $6 billion a year on research in HIV. 10 years ago, there were 6 times as many people with Alzheimer's disease, but we were spending 1/6 the amount of money on Alzheimer's disease research. So the relative investment in dementia was so lagging, it was unbelievable. And finally, and I give credit to the Alzheimer's Association, to all of us, frankly, on this call, clinicians, family members, politicians, everyone bandied together in the last decade and said, oh my God, we got a problem on our hands. We've got a burgeoning epidemic. We better do something about it. And we need targeted therapies. We need a cure. We need at least a disease-modifying therapy agent. And with the with the Alzheimer's plan that got there was a Massachusetts plan, and there was a federal plan, the Obama administration. All of this is like, we want definitive treatments on the market by 2025. Now the investment has essentially exceeded HIV. We're now getting, the increase in Alzheimer's research in the United States has gone up about 7-fold in the last 9 or 10 years. It's amazing. So what I think we're going to see in the next 5 years is rapid progress because of all of this slow, but now finally to the table investment. And I'll say one other thing. The treatments that first came out were symptomatic therapies. They were addressing 2 neurochemicals in the brain that were late-stage problems in Alzheimer's. The current therapies that are coming to market are addressing the biology of amyloid and tau. But there's a lot of other biological processes that are way more fundamental to the disease. One of our studies that Catherine talked about, nicotinamide riboside with oxidative stress and energy metabolism. So those are 2 mechanisms. We need to reduce oxidative stress in the brain. We need to target inflammation. We need to go after mitochondrial dysfunction. There are some basic biological processes that we know underlie this disorder and these disorders that we will be developing targeted therapies towards. And my guess is, like with HIV, like with cancer, like with diabetes and hypertension, you wind up with a multi-pronged approach. And all of these approaches biologically have to be augmented with the psychosocial interventions as well.
Thank you so much for that wonderful answer. I think it helps explains a lot of how we sort of arrived to where we are today. We have about 8 more minutes left, so I have 2 more questions here. Might have time for a third if anyone is so inclined. But in any case, we have the next question comes from Kathy, and Kathy asks, can people on blood thinners, due to potential stroke risk, are they candidates or are they able to engage in treatments such as lecanemab?
So Kathy's a really important question. For the first drug that got approved that I talked about, aducanumab, that got accelerated but not full clinical approval, patients who were on blood thinners were excluded from those trials. And the reason they were excluded is that early studies seemed to indicate a much higher risk of bleeding if they were on blood thinners because of the inflammatory effects of this drug in blood vessels where amyloid is sticking to blood vessel walls, causing hemorrhages. Now, there's a subtle difference in the mechanism of action between aducanumab and lecanemab, which allowed for AZI to design a trial that included people on blood thinners. So there's now a lot of data, which I don't have memorized, but there is definitely an increased risk of bleeding if you're on a blood thinner, but it may be reasonable for a given individual. So my guess is it will probably be allowed in certain situations, but it will be a case-by-case decision with careful informed consent so that the person who's receiving the treatment, who's on a blood thinner, will go over the numbers that we know from the studies done to date. Once this is more widely available for the public, we're going to get real-world data on this, because what I did not say is that one of the requirements to receive lecanemab in clinical care here in Boston is going to be participating on a registry. The Medicare is going to require that for them to pay for the drug, you're going to have to consent to have anonymous data collected from you regularly about your clinical outcomes and safety outcomes so that we know how to answer your question, Kathy, about are blood thinners actually safe and what is the real risk? So my guess is the answer is yes, they'll be allowed in certain situations, but careful monitoring is going to be critical.
All right. Laura asks, is the logopenic variant of aphasia a frontal temporal dementia? We have been told it is likely secondary to Alzheimer's.
This is a very detailed question, Laura. This gets into how there's a lot of overlap between different forms of dementia in terms of the clinical presenting symptoms. There are many variants of frontotemporal dementia that have now been well characterized. Some of these variants are more likely to be frontotemporal only. Some are more likely to morph into what looks like Alzheimer's disease, both clinically and biologically. So I'm not really sure the answer to your question, to tell you the truth. I think the way I would think about this is people who develop what's called primary progressive aphasia as the only symptom first, like they have difficulty with language understanding or expression of language, and memory's normal and functioning's normal, those people with that type of aphasia, primary progressive aphasia, could go a frontotemporal route or an Alzheimer's route. And like I said before, the longer someone lives at the age or the age at which someone is when these symptoms develop, the more likely you got more than one pathology going on. So again, this is where these nuanced questions are well beyond the guise of primary care and need to be answered in specialty memory centers with neurologists, neuropsychologists, and psychiatrists. And then the real question that I would ask, though, is what really matters to patients and their family members? Sometimes we won't know the definitive diagnosis, but we will know how it affects someone's cognition, function, and behavior. And if we could keep our eyes on the impact of this on functioning behavior, et cetera, that's really where we have an opportunity to make a dent, even absent a true disease-modifying therapy.
All right. So the last question I think we have here comes from Nancy, and Nancy asks, how effective can psychotherapy be for people with dementia who are dealing or coping with a diagnosis of depression, anxiety, fear, etc.? Are there any therapists who specialize in working with patients with dementia?
Nancy, this is an awesome question. First of all, there needs to be more literature on this. This is a hugely important topic. There are issues that come up all the time about what happens when someone finds out they have dementia. Are they at risk of wanting to die or kill themselves? Are they likely to suffer from depression? I think it's really important that people who are dealing with the angst, the grief, the denial, the minimization, the fear, and the anxiety related to the diagnosis or the impact it's having on their life now and in the future, psychotherapy is critical. And if you have the capacity as somebody with dementia to remember and retain information, and you benefit from processing these complicated feelings, I think it can be critical. I wish we had more research. Chris, I'm curious what you would say, since this is an area you specialize in. And we have other people who specialize in this, because that's part of Nancy's question.
Yeah, I would say this question does come up a lot. There are a couple things I will say. Number one, I think it very much depends in terms of where a person is in terms of the disease progression. If we're talking very early stage versus, moderate to later stage, with psychotherapy, one of the key, I would say, components to having a beneficial clinical outcome is, being able to retain, the work, quote unquote, from session to session. There are some clinicians that I have encountered that do specialize in working with patients that are diagnosed with early stage, either MCI level or early onset Alzheimer's. Though what they tell me, though, is that as the disease progresses, there does come a point when the clinical relationship is untenable because the disease is preventing the short-term memory retention from session to session. So I think that there's a lot of benefit to be had, especially for those that, already benefit from therapy and processing emotions and being able to essentially unload. And just as a stress reliever and, early stage folks that, might be holding in a lot of fears, anxieties, emotions regarding, having this diagnosis, there's certainly something to be said for the benefit of that. Though in later stage, again, due to how this disease works, the benefits tend to, wane over time. I will say, though, that, if you're interested in therapy, it's better, in my opinion, to explore these options, sooner rather than later. Dr. Forster, as you said, being more proactive rather than reactive. And there are some that do specialize, however, they are somewhat difficult to find. The National Association of Social Workers, the NASW, actually has a service that I often utilize called Therapy Matcher. And Therapy Matcher has a network of clinical social workers that provide different types of therapies. And there is a very small subset of clinicians through their network that actually do specialize in early stage MCI. So it is something that's out there, but I would talk with your care team to try and see about getting connected with somebody who might be able to help.
A colleague of mine in New York, just to say, Chris, Demetrius Kiosis at Cornell is doing some wonderful research on depression in people with MCI. So there's for psychotherapy intervention. So there's definitely some work in this area that's being done now. And I couldn't agree with you more that it can be really helpful at the right stage of illness.
Absolutely. All right, and so that brings us right up to 7 o'clock. So I want to thank Dr. Forester, and I want to thank you as well, Catherine, for joining us tonight. I think it was fantastic and very informative. The presentation that you gave us will be sent out to everybody here on the call. So if you came in late or if you missed something, don't worry, we'll be sending it out. The recording of tonight's presentation will also be available on our website, dementiacarecollaborative.org, within about 10 business days or so. Give us a little bit of time. But in any case, again, I want to thank everybody for joining us tonight. I hope everyone has a wonderful rest of your evening. And from us here at the Dementia Care Collaborative and Dementia Caregiver Support Program, have a great night, rest of your week, and take care.